Dr. Antay Waters. I'm an assistant professor of nursing at East Texas Baptist University in Marshall, Texas, preparing our next generation of baccalaureate professional nurses, as well as a CNM hospitalist with OB Hospitalist Group at Christus St. Michael's Health System in Texarkana, Texas, providing high-quality, evidence-based care to women of Northeast Texas and Southwest Arkansas. In the February 2024 issue of Women's Healthcare, I provide an overview of caring for individuals with various types of anemia during pregnancy. Anemia is the most common hematologic condition affecting individuals during pregnancy and the postpartum period. There's a rising trend in pregnancy-associated anemia in the United States, as well as increasing disparity by race, ethnicity, and socioeconomic status, with iron deficiency anemia being the most prevalent type. Among WIC participants, approximately 1 in 10 is affected by maternal anemia. Severe anemia during pregnancy is associated with an increased risk of both maternal and fetal infant morbidity and mortality. There's also an association between severe anemia during pregnancy and preterm birth, low birth weight, small for gestational age, and perinatal mortality. A systematic approach should be undertaken to appropriately diagnose maternal anemia based on its characteristics, with iron deficiency anemia being the most common. As part of the diagnostic process, clinicians should remember that racial disparities exist related to the distribution of hemoglobin and hematocrit. Because these etiologies are poorly understood and the use of varied criteria may lead to gaps in care, the same diagnostic criteria should be used for all patients. Factors that cause a generalized increase in hemoglobin and hematocrit levels should be considered when interpreting test results, such as maternal tobacco use and living at a high altitude. Measurements of serum hemoglobin or hematocrit are the primary screening tests for identifying anemia, but are not specific for identifying iron deficiency. Serum ferritin levels have the highest sensitivity and specificity for establishing a diagnosis of iron deficiency anemia. All pregnant patients should be screened for anemia during the first trimester and again between 24 and 29 weeks gestation. ACOG and the CDC recommend all pregnant patients begin low-dose iron supplementation during the first trimester to decrease the prevalence of maternal anemia at delivery, except in the presence of certain genetic disorders such as hemochromatosis. Iron deficiency during pregnancy is one of the strongest predictors of postpartum anemia. Consideration must also be given to the significant and often under-recognized association between anemia and postpartum depression, even in pregnant patients without a history of mental health disorders. Recent studies indicate a significantly higher rate of postpartum depression in individuals with postpartum anemia than in non-anemic individuals. Depression during pregnancy and postpartum depression are among the most common complications related to pregnancy with a significant public health consequence. Primary prevention during pregnancy begins with comprehensive patient education, ideally beginning prior to pregnancy. Clinicians should provide information and referrals for those in low socioeconomic statuses and with health disparities to provide access and resources to healthier, iron-rich foods. The prevalence of anemia during pregnancy has continued to increase over time, with notable racial, ethnic, and socioeconomic disparities. It is often overlooked and dismissed as clinically insignificant. However, severe maternal and fetal complications are often preventable with equitable implementation of public health and clinical strategies. As clinicians providing prenatal and postpartum care, the implementation of recommendations and providing comprehensive patient education related to primary prevention rests with us.